As a steward for effective and scalable interoperable data exchange, MiHIN is deeply involved in many of the national collaboratives and working groups that support this work. For SDOH, that national collaborative is called the Gravity Project. They have a great deal of information publicly available, and they're a great resource for questions about what the SDOH domains are, the codes that are associated to specific domains. The Gravity Project created a self-assessment tool that enables organizations such as MiHIN to determine where they are in their SDOH Health IT maturity model in the form of tiers. Really briefly, Tier 1 indicates that social risk data, inclusive of screening, diagnosis, goals, and interventions, are documented in a structured manner. Tier 2 means that you've not only adopted gravity-vetted data terminology, but that you're also exchanging that information within established data transport mechanisms such as HL7, CDA, and Direct. Tier 3 means that you're fully on the FHIR SDOH implementation guide. Ultimately, it is our goal here at MiHIN to get to this tier, as it means that we can finally move away for manual FTP uploading and spreadsheets for upload. MiHIN's SDOH use case will move us in, with version 4, will move us into tier 1 of the Gravity model. Next slide, please. And really briefly, a few highlights of what's changing for those that are already participating in our SDOH use case and on version 2 and 3 of our specifications document. Version 4 will aim to refine fields to simplify and clarify data requirements to better the data validation processes. As mentioned before, we're moving towards LOINC-coded screening responses. We'll be adding a requirement to include at least one of the following fields: phone number, SSN4, and address to better our patient matching processes here at MiHIN. We're seeking to eliminate the information previously requested from the SIM projects, including Z codes. Ultimately, this gives us better ability to move towards the tiers 2 and 3 of the Gravity Project and better align to the HEDIS measure for electronic social needs screening. Next slide, please. So without further ado, we're going to move into the review of the version 4 specifications. As a reminder, this is in draft and is subject to change. Next slide, please. We've broken the new specifications into 3 sections: file management, patient demographics, and screening information. We'll start with the first section related to file management. At the top, we break the columns into data element, type, maximum length, description, required or optional, and field purpose, where description and field purpose provide supporting information for each data row. Submitting organizations should include the source name, source OID or organization ID, and row IDs. Some important notes here are that the source name can be different from the screening organization itself. So for example, organizations that are sending in SDOH data on behalf of multiple practices. The row ID should be numbered in numerical ascending order, such as 2, 3, 4, 5, and 6. You'll notice that this is an optional field, and in cases that row IDs are not provided, MiHIN will assign them when it receives the file. These data elements give MiHIN the key information we need to appropriately troubleshoot a submitted file. If an issue arises, we can get right down to who the submitting organization was by name and unique OID, along with the specific row of data in the cases where a row of data is in contention. Next slide, please. Thank you. The second section is all about the individual, or basically the who was screened section. For those that have never submitted SDOH data to MiHIN, we ask for screening information at the screening and individual levels, meaning if you screen a patient once, twice, or 3 times, they go onto this file with their demographic information. Starting at the top, the screening unique ID is your system's identification number. This typically is the medical record number, or MRN, for healthcare organization submitters, but generally can be the source system's ID identifying the individual. This is a care field, meaning that it can be alphanumeric. Next up, with the Social Security last 4, which is an optional field. Following that is the common key, which is MiHIN's unique key number for the patient that we've provided back to you as a common key or CKS use case participant. This is also optional if either if you're a first-time participant or simply unsure if you have this number. Now, I do recommend that if you do have a CKS number by MiHIN, that you store this number into your own patient records as well. This will help this will help us all in aligning patient information stored at MiHIN to your own. First, last names, date of birth, sex are all required fields here. Race and ethnicity information are optional, but if an organization does choose to provide this information, we do ask that you follow the CDC's codes to greater support data standards. All other address, city, state, postal code, and mobile and home numbers are optional fields. As I had previously stated, please do aim to provide any one of the additional optional fields to support better patient matching at MiHIN. Final note here before I move forward, we have heard from organizations that have submitted SDOH data that running their reports from the patient level first is the most helpful way to start and ensure that you've covered all the patients that have been screened in comparison to running all your screening information reports first and identifying the who. Next slide, please. Now that we've got the file management and the individual identifying information covered, we're going to move into the screening information section. This section tells us about the screening, starting with the screen ID. A screening consists of multiple questions for multiple domains with multiple responses of yes, no, maybe, did not share, etc. This is one unique screen ID. This is accompanied by the screen date. In general, if you've screened an individual multiple times, we want to include the question and answers for each screening event by date. Next up is screening practice name and OID, which again is the organization identification number, identifying the practice location in which the screening is attributed to. And then the screening questions code and answers are in LOINC code version 2.76, the latest version of LOINC. There are thousands of LOINC codes, and for this use case, we are adopting the Gravity Project SDOH approved LOINC codes, which can be referenced on the link under the field purpose. Now, I'll be going over an example of this during this morning session. Next is the intervention category, which is also required, and we ask that you only use the values listed here, which actually align with HEDIS electronic social needs screening measure and are the following: assistance, assessment, counseling, coordination, education, evaluation of eligibility, provision, referral, or none. An intervention date representing the date of the intervention, and finally, the screening provider ID, MPI, and first and last name. Please note that these are optional fields. Next slide, please. Now that we reviewed the specifications document, let's go through compiling a file for the draft version 4 of the SDOH use case. Next slide, please. So let's say you've got your report of individuals screened with date, with who screened the individual, and with all the LOINC codes from your system. You'll want to narrow it down to only the approved LOINC codes as sponsored and updated by the Gravity Project for SDOH. To find those codes, go to the Gravity Project Value Set website, whose link was previously provided. Next slide, please. I'll then click on one of the many SDOH domains supported by Gravity. Depending on what SDOH domain you click on, the site will actually take you down to the domain section. For example, I click on the food insecurity domain. Next slide, please. I want to then click on the Food Insecurity Assessment Instrument Codes version 1 to download the Food Insecurity LOINC question and response codes. Next slide, please. Opening that file gets you to the question and answer LOINC codes that are applicable. The assessment instrument is also known as the screening tool / questionnaire name. The panel LOINC code represents a code for the complete questionnaire set. The panel name is the translated name in the LOINC library. The common long name is the question translated by LOINC, while the question as the assessment instrument is the question as per the assessment instrument itself. The answer list code provides the codes of answer responses to each of these questions. Next slide, please. Continuing on the next page, you can see that each question is represented here, while each answer is not. Please follow the answer list code to get to that applicable answer, which I'll actually cover in the next slide. Next slide, please. Now, if you're someone who does prefer using the web version of this, you can simply use that panel code of the LOINC website to get to the questions and answers. Here, we're going to use the panel code 96777-8 for the Accountable Health Communities Health-Related Social Needs Screening Tool. You'll get each of the questions and their LOINC code, such as the 88122-7, representing the question of within the past 12 months, you worried that your food would run out before you got money to buy more. Next slide, please. As mentioned earlier, the answer code set provides 3 LOINC codes for each of the responses: often true, sometimes true, or never true. Often true is coded as LA28397-0. Sometimes true is coded as LA6729-3. And then never true is coded as LA28398-8. Next slide, please. So bringing this all together, we can now put together the file for submission to MiHIN under our SDOH use case. Next slide, please. For our fictional Lansing PO with an OID of 5.1.9.7, you'll notice that the name of the patient is repeated multiple times because, as a reminder, and as an SDOH use case, the key information here is the discrete screening question and response. Address 1, city, postal code, state, and mobile and home numbers are also provided along with the common key number. Now, this is an example of a very complete set, meeting all required and optional fields as described on our specifications document in previous slide. Next slide, please. Next are the screening information. We'll start again for your screening ID, labeled ABCDE, indicating that the following LOINC codes are for this one screening session on February 1st, 2023. You see the LOINC codes that the submitter has documented on their systems, making it easier to output here onto this file. The intervention category and date of the intervention was also provided, indicating that the individual was referred on February 2nd, 2023 to the next provider. And finally, we have the provider NPI, first and last names for the individual at Lansing Family Medicine that screened this individual. Next slide, please. Finally, we do want to close my portion of this, and we can jump into questions and answers with a reminder of the important dates. MiHIN plans to cease the onboarding of any current other versions of SDOH specifications to only version 3 of 2022 in October of 2023. We'll be planning on updating the system to version 4 by July, and we hope to go live with version 4 of the SDOH spec. This will give organizations about 5 months to move over to the new version 4 specifications by January of 2025. Next slide, please. And at this point, I think we're going to move into maybe questions and discussions. And I do see some chat and question and answers. I wasn't able to monitor them, but we wanted to leave this portion for a good amount of time for everyone to get their questions in and hopefully get some answers.
So I do want to take a minute because there was one question that was highlighted it was someone from who was currently using the old state innovation model required tool. And yes, the lift to overcome that non-standardized space is big. We get that. We understand that. We're trying to give as much time as humanly possible to overcome that. There are a couple of things from that tool that I've heard surface over again. I want to make sure is clear. The state innovation model was really a demonstration. They were looking for a lot of different things in that demonstration. So there are questions in there that are not necessarily aligned with gravity project domains for social needs. Things like, have you been to an ER in the last, 6 months? Have you had 2 or more visits? Or questions like those that are really designed not just to get after, was a need identified and what was that need, but rather for organizations to be able to stratify and figure out what to do with that social needs screen. Just because MiHIN does not require that does not mean that you cannot continue to ask those questions. That's not part of a state innovation. That's part of the work that you are doing. If it's valuable to you as an organization, then continue to ask that, but there's no way for us to be able to take that information in post state innovation model. The other thing that it's really important to understand coming from that state innovation model day is that housing was just recently converted from a single category or single domain to 3 individual domains. So you could see the need to be able to clarify, is a person homeless? Are they insecure, meaning kind of they're housed, but they're maybe couch surfing? Or housing insecurity, meaning insufficiency, is the problem actually related to, I have a house, but I can't really live in it because there's so much mold. So there are 3 different categories because they get after 3 very, very different things. Yes, I want to highlight that everyone involved recognizes the lift that it will take to get over the hump of non-standardized screening questions and answers, but it is a lift that we absolutely need to make in order for that information to be valuable. The work that Van did, going through those gravity project codes, there is a tool that we tried to kind of give to help people navigate that site. So those are available on our website. And I just want to make sure that anything gets we're trying to give you as many resources and tools. If for some reason you come across something that you're like, oh my gosh, if you could help us develop a tool like this, let us know. Something that would help you in the work that you're trying to do. All right, so I'm going to shut up now and turn around. And Joanne, what questions do we have?
So I put in the chat that gravity project guide that we kind of just got up on the website, along with the new website page, which has links to all of the file format specs and some other resources. We have in our questions and answer, this is from our friend Diane Marriott, and Diane, you may have to come off mute and give us a little bit more. What is a TPO pathway?
That would be treatment, payment, and operations pathway. That is really follows HIPAA. That is not a MiHIN term. That is really consistent with how data flows within healthcare specific spaces. So if an organization has a treatment, payment, and operations relationship, that data needs to go to those organizations, or the organizations that are engaged in that relationship have the legal access to that data. Diane, does that answer your question? Feel free to come off mute.
There's a lot of good stuff happening in the Q&A. I don't know if everybody can read the Q&A, but I don't know if it would be valuable for us to say that stuff out loud.
Okay.
There was a good back and forth about, you had just said people still using the state innovation model SDOH survey and LOINC codes for those questions. And then Lisa, you had sort of dug in there. Will MiHIN be accepting the same domains as Gravity? Several domains listed in the Gravity material, but not in MiHIN's list of domains. Van, you answered and said that we will be accepting all approved Gravity projects that have an assigned LOINC code. Does anybody else have other burning questions, or not even burning, just sort of like, even, do you want to take a step back? Did we move too fast? Are you seeing what you need in the questions and answer? Let's
Have a discussion.
Yeah.
Jump off mute and join the party.
Which additional demographic fields are now required?
Bam.
Yeah, I can go back to that. There are no, we tried our best not to add any additional demographic fields. What we actually did request was that you included one of the optional fields in addition to the what we call our base 4 demographics. The base 4 being the individual first name, the last name, the date of birth, and the sex. And then those optional fields, like I had mentioned earlier, would be Social Security 4, would be the common key, would be the address 1, address 2, city, postal code, state, mobile number, and phone numbers.
And it's important to note that it's not, so this really relates to the ability to positively identify someone. So again, if this information is valuable enough to be able to dig in and really get people screening, and we know that it holds transformational capacity within our system, it's important to make sure that we can match the right human being. So the more data that people are willing to kind of provide that allows that person to be positively identified, and if there are questions, that secondary information really helps our teams to be able to resolve identity. And that's going to be very important as we look to move beyond social needs screening in healthcare and be able to do this work in healthcare and community, because the way community organizations match may not be the same way that we do within healthcare. Joanne, I saw something flip up. Was there another question
about new legal agreements?
Sure.
But I'm not sure that people understand. Let's talk about what new means and legal agreements mean for who.
What was the specific question? Sorry, I'm trying to find it.
When will new legal agreements be available for review? I think, Melissa, new legal agreements for who? This is from Melissa Kirshner.
Melissa, do you currently share data? Because if you do, then you don't need new legal agreements. Those legal agreements, if organizations already have signed on to the MiHIN legal stack, that will be the case going forward. There's no new legal agreements for you. There are new legal agreements where we are piloting, bringing in data from community. We have to pilot this initially because we need to understand how does this work and work out the bugs before we actually open this at a broader scale. So we are looking to do that currently, both in SDOH, in the social needs screening use case, as well as in our interoperable referral use case. But the simplified, scaled down legal set of agreements, again, benefits all of us. It has been drastically reduced in terms of the volume of legal documentation. I think that is a sign of MiHIN recognizing where we are within this broader space that that meeting organizations where they are benefits everyone within our network and within the state of Michigan, because when we make data available to organizations, not just those organizations with a team of legal professionals ready for beck and call, but everyone, then we strengthen our healthcare system, we strengthen our social care system, and we make better choices. when we have accurate data. Melissa, it looks like we answered that question for you. So I think we're good there. Bruce Kelly, if an MA with no NPI is asking questions on behalf of a provider, should we use the physician's NPI or leave it blank? Family.
Sure, and I chose to answer this live. Thank you, Bruce, for sending this question in. You can do either. It's up to your preference. We do prefer that you have a provider's name in there, but again, you can also list the MA if you'd like, and leave the NPI portion blank, indicating that this is potentially not a healthcare provider. So it's really your choice. We're not going back into your systems and doing any type of audit, for example, to go back and say and prove that that was the individual that did the screening themselves. Hope that answered your question, Bruce.
And then Van, I think the following one by Stephen, in the file you ask for results, status of referral or care coordination, etc. What if someone is asking for more than one of these domains? Are you talking about what if someone is asking if somebody screens positive for healthcare or for housing, food, and utility? How do they manage the outcome or the result of each one of those?
Yeah, so I think here, so to answer your portion of it, Lisa, we are looking for individual screening, all the individual screening questions and responses to them. Now, I think Stephen's asking about the intervention category as well as the intervention date. And so if you provided, as a result of your screening assessment education materials to that individual, as well as, let's say, a referral in there as well. In our spec, we are going to allow you to list both. We do prefer that you list the one that's most updated. So if you did provide education material, but then ultimately resulted in a referral, that if you had to choose just one, you would list the referral. And again, there's no LOINC codes right now for the type of intervention. We'll certainly, as we move through the tiers of the gravity model, look for more standard data, but we're adopting what aligns with currently with what we see in HEDIS for the electronic social needs screening measure.
Van, there's another one here. Do the SDOH values need to be codified by the source, whether or not it's an EMR, or are mappings from non-EMR sources acceptable?
Yeah, the latter. Mappings from non-EMR sources are acceptable. We obviously recommend that it's mapped at the source level as well, so that you can actually run these reports in a more routine basis and kind of remove the manual entry portion of it. But an understanding that obviously not every organization that's doing this work, it has an electronic medical record. We certainly are accepting mappings from non-EMR sources.
Great. And then Bruce Kelly had a question. Will the POs get this file from MiHIN based on our acres from other providers? So that is one of the highlight and purposes as to why we need to be able to make this data more exchangeable, is because right now, the people who are clamoring for this data is really payers, right? So they want to understand more about the population. But as risk is translated more and more through risk-based payment models, it's really important for provider organizations to also have that. But right now, those questions and answers are coming in text-based format. So it makes it very difficult for anybody to be able to do anything with that in terms of aggregation. So the SDOH use case is a bidirectional use case. So yes, you have every ability to be able to get that that data file based, but like right now, how would you take that in and make use of it in an electronic system? But yes. Susan, I tried to follow the link to MiHIN.org, and because we are a housing and service provider, not medical, I am unable to obtain access.
I think maybe she was looking at the Gravity site and not our not the MiHIN site. I hope, Susan, that we helped you out with that.
Okay, there we go. Sorry, it would be helpful if I just kept reading down, right?
Yeah.
Sorry about that.
Do the SDOH values need to be codified by the source, or are mappings from non-EMR sources available?
Covered.
Sorry.
Van covered that one. Yes, mappings are acceptable.
You did it. Okay. Loving the questions, loving the engagement. You know, Bruce, we just answered your question. It was sort of a, yeah, that's our, Bruce Kelly said, will POs get this file? And we said, yeah, that's kind of like the point. But Bruce, I don't know if I allowed you to come off mute. But do you know, what are you envisioning? How would you use this information? And, you know, even if you were getting it sort of in the way it comes in now. You don't have to answer. It's just, these are the types of things, you know, yes. And how would you like it? And how would you even use it if we were, you know, not evolving our file format, which is sort of like what we're trying to get to. We would love to learn from you too. Amy Robertson. What's the best way to ensure that multiple resources are not reaching out to the patient? The internal health system is also reaching out. And will patients be targeted by multiple resources and find that overwhelming? I don't know. And Lisa, this might be like an interoperable referral, you know, type of answer.
It really is. So I think that this is kind of one of the biggest things as we continue to get kind of healthcare organizations screening for unmet social needs and referring them into the community, but without a way to be able to close loops and really understand what is happening in there, and literally passing on the baton, like I think like a nurse. I'm a nurse, right? Like I do a report out and I know that that person has the next steps. And when I receive a report out, I know I am in charge of what is happening there. And I know that who I pass off to has the appropriate knowledge and skill and tools to be able to help that person best next. But as we're kind of broaching this work between health and social care, I think that those things are really kind of not as clear. I'm not going to say that I have all the answers or that MiHIN has all the answers or that the answers have really been figured out at a national level. We are in the infancy of this work. This is not a problem that is going to be solved in 2, 3, or 5 years' time. So we really have to be able to pull together on this and be able to utilize data to make sure that we are doing the absolute best that we can. This is not simple. We understand that this is a complex piece. And I will say once again, you know, that in the interoperable referral space, there are many, many organizations who are like, well, why can't we just use all one single system? We'd make it so much easier. And yet it really undoes a lot of the value that is already housed within the community. The community, not everyone uses a system of record, but that we do have organizations who have developed systems of record, and they want to continue to operate within that system of record and not lose the capacity to be able to maintain that data. So being able to close a loop and understand who has picked up that baton and the care for that individual is critical, but it is critical to not impose more administrative burden on social care providers or our medical care providers. No one in this space has that capacity anymore.
Do we have plans to prepare like a crosswalk from that prepare tool?
Well, I mean, you kind of already have that in the Gravity codes. So you can look at the Gravity codes in that tool. You can select the prepare tool, or you can select the specific domain that you're looking for and understand how that prepare tool maps to a LOINC code. So yes, prepare is a very widely respected codified tool. It's great. If that's what you're choosing to use, you're in golden shape.
Yeah, and you can also review this. I think recording of this is going to be available for our attendees as well. So in one section, I did review the LOINC panel code. So if you're interested, you can find the LOINC panel code for Prepare, and it will have in the LOINC website every single question with domain as well as all the answer codes associated to each question as well. I know it can be overwhelming. There are thousands, but I think from LOINC's perspective, they do put together a nice little user interface to help navigate that.
Do we have a link for that, Van? Should that go on the?
That's the PDF that you
Sure.
attached.
Oh, okay.
That will help people walk through it. It's a pretty explicit thing, but it gives you the pointers to how they can get started as they start to use this the value sets and the codified answers. Other questions? I have used lunch
I
codes
see
for
somebody
many
has their
years.
hand up, but I don't know. Maybe it's Susan. We don't stand on ceremony here. Don't even raise your hand. Just
Yes.
speak. Like we will not
Jump in.
Yeah. Hi.
Hi.
Hi there.
So I was trying to get in to the Gravity Project website and followed the link, and then I don't have a VSAC login. So my difficulty was when I was trying to go through and request one, I followed the identity providers, and then at the end of it, it basically said this is a restricted medical area and we're not giving you access. I mean, I'm abbreviating. So I'm wondering if there's any kind of a workaround, because we strictly would be a social housing and service provider, not a medical provider. So I'm not going to qualify if that is a requirement.
I think as you go into that specific, that's probably going to give you overload. You're probably going to run screaming if you go into that kind of like that other set. Use the tool that we put the walkthrough that will help you to get to where you're going to go. They can't tell, like anybody, it's a website, right? They can't tell that, oh, that person's from housing. You're not gonna so you're going to be able to get to what you need. Medical care providers may choose to go into something different, but that PDF that is available on our website that was dropped into the chat, that's really what you want.
Yeah.
Okay, I'll check that out more thoroughly then.
And
Thank
please, if you have a problem, please don't hesitate to give us a call. We can jump on a 10-minute, webinar or call and walk you through it. It would be great. We'd love to be able to do that. Questions? I think we have 5 minutes left.
We will be sending out the slides. We will be sending out the recording. All of the stuff is also cataloged and inventoried on our website. So yes, and yes. I also put my email in the chat. If you need anything, you got me. And I can get to Lisa and Van. I text them all night long.
And I think I personally, and I know Van and Kayla as well, we all recognize that in early adoption of this work, some of the hazards of adopting this work early is that you make an educated guess and you kind of move in that direction. And sometimes you have to course correct. And this is a course correction, but I think it is one that will benefit the state of Michigan, the residents of the state of Michigan, the organizations that serve the state of Michigan, residents and our payers and our providers. So we want to make this as smooth a transition as possible. If you have questions, doors are always open. Please just reach out directly. Yeah. I'll show you.
11:56 for the good of the group. Anybody have any lingering questions or concerns? Do you want to bring up, drop a bomb and then just head on out?
Walk away.
We love that. We love that. Please. Hearing nothing, seeing no new questions, seeing no hands, I think I will call it 3 minutes early. Thank you very much for coming and for working with us, and for being on this journey with us. You know, we intend to transform healthcare, and it's not going to be easy. It's going to be messy, but it's our lot in life. Thank you.
All right.
Thank you so much for coming.
Thank you, folks.
Thank you for being a great audience. Have a good day, everyone.
Take care.
Thanks, Lisa. Thanks, Van.
You're
Thank
welcome.
you. Bye-bye.